consultant psychiatrist with the Federal Medical Center, Jalingo, will be taking us on a very interesting topic, that is choosing the right antipsychotics in clinical practice. And I know this topic will do us well if we pay keen attention, because we are all doctors here. We have met different patients. Even if you're not a psychiatrist, at some point in time, one will need to act before sending to the right person. So we should pay keen attention as you school us through this very interesting topic. So, Dr. Chimbo Chijioke, if you are hearing me, I think you can take over from here. Thank you very much, sir. And thank you, ladies and gentlemen. You have the floor, sir. Hello, can you hear me?
Please ask him to unmute himself.
Hello, good afternoon, sirs.
Good afternoon.
Good afternoon.
Good afternoon.
Okay. Good afternoon. Good afternoon, senior colleagues.
Hello, please. I don't know whether it is my system. I barely can be able to hear the speaker. Please, can we work on it? Or is it my system? Can every other person hear clearly?
Yes, we can hear clearly.
We can hear him.
Yeah, clearly.
Okay. So, good afternoon, senior colleagues, every other person listening. I am Dr. Chimbo Chijioke, and I am a consultant psychiatrist here with FMC Jalingo. Today I'll be talking on the topic, choosing the right antipsychotics in clinical practice. And I'll be doing that under the following outlines. First, I will outline the learning objectives. I will define psychosis. I will explain what is meant by the term antipsychotics. I will outline some of the indications for antipsychotics. I will talk about types of antipsychotics, their mode of action. Then I will go to the nitty-gritty of the presentation, talking about factors to consider when choosing our antipsychotics. I will talk about contribution of antipsychotics. Then I will take a few case witness before I conclude. Now, for the purpose of this presentation, we are supposed to have understood what is meant by antipsychotics and when they are needed in clinical practice. That is by the end of the presentation. We're also supposed to know the major properties of the commonly prescribed antipsychotics in our environment. Similarly, we're also supposed to know the factors to consider when trying to choose an antipsychotic for our patients. Then we're also supposed to know some of the relatives and absolute contraindications of antipsychotic prescriptions. Now, what is psychosis? Psychiatrists define psychosis as the experience of one or more of the following: delusions, hallucinations, disordered thinking, and extremities of motor activity. Now, delusions are abnormal beliefs that are held on inadequate grounds. They are usually false, they are fixed, and they are unshakable. Now, they are not the type of beliefs such a person is expected to hold given its educational, religious, or cultural background. Now, an example of a delusion could be a person who believes his neighbors come into his house in the night to try to poison him. Now, this is a type of persecutory delusion. Other types of delusions include grandiose delusions, delusions of love, delusions of jealousy, nihilistic delusions, to mention a few. Now, what are hallucinations? Hallucinations are false perceptions in the absence of a stimulus. Now, there are different types of hallucinations. There could be visual hallucinations, auditory hallucinations, tactile, to mention a few. Another of the criteria for defining psychosis is disordered thinking. I will not bore you by talking about disordered thinking. I expect every person knows disordered thinking, because what it actually means in English is what it means in psychiatric practice. Now, disordered thinking can also cause extremities of motor activity. This could be psychomotor agitation or psychomotor retardation. Now, when thinking is disordered such that a person thinks faster, he talks fast, and he's restless, he can also be agitated. Now, this is an extreme. The other extreme is psychomotor retardation. This is where a person thinks slowly, their thoughts are slow, their speech is slow, and as such, their actions are also slow, and this is known as psychomotor retardation. Now, psychosis tend to distort thoughts and emotions, and in such a person, the reality. Some of the causes of psychosis could include genetics, life events, substance use, and disease conditions. Antipsychotics are drugs used to treat psychosis and related conditions and symptoms. These medications work by correcting the imbalance of certain chemicals in the brain. These chemicals that we all know as doctors are known as neurotransmitters. Now, antipsychotics can also be used in different settings outside psychiatry. They could be used to manage hiccups, hyperemesis. I will come to all this later. Now, what are the indications for antipsychotics? Some of the indications of antipsychotics I will just mention briefly are schizophrenia and related psychosis. These related psychosis include things like delusional disorders, schizoaffective disorders, transient psychosis or brief reactive psychosis, and abnormal behaviors that can also result from substance use is also an indication for antipsychotics. Antipsychotics can also be used to manage psychotic depression and bipolar disorders. Similarly, in low doses, antipsychotics can be used to treat behavioral and psychological symptoms of dementia. Also in low doses, they can also be used to manage agitation and delirium, occipital psychosis, and intellectual disabilities. Now, these medications are often taken for quite long duration of time, and as such, it is good for the clinician to know the side effects and some of the implications of prescribing these medications to their patient. Now, types of antipsychotics. Antipsychotics are basically classified into two types. First, the first generation antipsychotics, or the typical antipsychotics. And secondly, the second generation antipsychotics, or the atypical antipsychotics. Taking the first generation antipsychotics first, these type of antipsychotics are generally cheaper. This might be because they are older in the market and they have more side effects, such as extrapyramidal side effects. I will pause briefly to talk briefly on extrapiramidal side effects. Now, what are extrapiramidal side effects? Extrapiramidal side effects are side effects of antipsychotics that are related to motion. Now, these side effects include things like acute dystonia, that is lessening the rigidity of the patient, tremors, Parkinsonism. It could also, they also include oculogenic crisis, tardive dyskinesia, and akathisia. Now, I wouldn't bore you much by talking more on extrapiramidal side effects, but these are side effects that are noted mostly among first-generation antipsychotics. Then another property of first-generation antipsychotics is relative increase in serum prolactin levels. This, like we all know, can cause gelaturia, can cause osteoporosis, amongst other things. Now, first-generation antipsychotics as well, amongst them, tend to have lesser extrapiramidal side effects. They tend to have greater sedation profile, and they also tend to have hypotensive effects. However, the hypotensive ones among them have greater extrapiramidal side effects and lesser sedative effects. I know this is a bit hard to understand, just itemizing them without a table or without the antipsychotics listed. I will list the antipsychotics in the next slide, and a table will follow after this particular slide. Now, these first-generation antipsychotics are more effective for positive symptoms of schizophrenia. Now, what are positive symptoms of schizophrenia? These are symptoms of schizophrenia where clinical symptoms that the patient did not present with appears in the patient. Clinical symptoms that were not there appears in the patient after the onset of schizophrenia. Now, this can include delusions, it can include hallucinations. You agree with me that patients, everybody generally do not have hallucinations, but when schizophrenia develops, hallucinations appear. So they are known as positive symptoms of schizophrenia. Still on the typical antipsychotics, I will now list the types of typical antipsychotics. Mind you, I will mention only the ones that are available in our environment. Now, first among the typical antipsychotics is the phenothiazine group. The phenothiazine will be aliphatic phenothiazines that include chlorpromazine. It will be the pyrazine phenothiazines, such as tioridazine. By the way, tioridazine has been withdrawn from the market by the manufacturer. It's no longer prescribed because of some side effects, cardiac-related side effects. Then piperazine phenothiazines, such as tripyrazine and fluphenazine. Likewise, we have the butyrylphenone type of the typical antipsychotics, and this group includes haloperidol. Then the thiazotines that include flupentazole and cyclopentazole. Now to the second generation antipsychotics. These antipsychotics are more expensive. They are newer in the market. In other words, most of them were discovered a few decades ago. They have lesser side effects, particularly they have lesser extrapiramidal side effects, and they have higher metabolic syndrome. They have higher propensity to cause metabolic syndrome. These medications are also believed to be more effective for the negative symptoms of schizophrenia. I will also go ahead to explain negative symptoms of schizophrenia. Now, negative symptoms of schizophrenia are symptoms of schizophrenia that disappeared from the patient's life after the onset of the schizophrenia. In other words, these symptoms where the patient had these properties, then on the onset of schizophrenia, these properties are no longer with the patient. Such symptoms include anhedonia, that is inability to enjoy things the patient used to enjoy before, asociality, reduced social life or reduced ability to socialize, alogia, reduced ability to talk or interact. Then flat affect, that is reduce emotional variability to stimulation. Now, examples of atypical antipsychotics. I will also in these examples mention mostly the ones that are common in our environment. Now we have the benzoyl derivatives. In this group, we have the risperidone, the tenobenzodiazepine. In this group, we have olanzapine, the dibenzodiazepine, in which we have clozapine, the dibenzodiazepine group, where we have quetiapine, the substituted benzamides, the group where we have amisulpride, and then the benzotiazole, where there's ziprasidone, and then the quinolone group that has aripiprazole. Now, this is a diagram that items the categories of two major categories of antipsychotics, the typical and the atypical, their mechanism of action, and the common examples involved in these groups. Now, the typical antipsychotics, like you can see the mechanism of action, these antipsychotics block dopamine receptors in all parts of the brain. We will go ahead to explain the implications of blocking dopamine in some parts of the brain. There are actually four major pathways of dopamine in the brain. Now, these are the typical antipsychotics, and examples of them include carbamazine, haloperidol, fluphenazine, and trifluperazine. These are the most common ones in our environment. Now, the atypical antipsychotics. This particular table divided them into two. We have the dopamine and serotonin antagonists. These ones block dopamine and serotonin receptors in the brain. In the group, we have the amisulpride, the clozapine, olanzapine, zotepine, and quetiapine. Now, this particular table failed to mention risperidone, so you can comfortably add risperidone to that group. Then the partial dopamine antagonists that blocks only a portion of dopamine receptors and also block serotonin receptors. In this group, we have the aripiprazole. Now, I'll briefly talk about mode of action antipsychotic before we go into the nitty-gritty of the presentation. Now, antipsychotics, like I said before, correct the imbalance of neurotransmitters in the brain. Now, these neurotransmitters involved are mainly dopamine, serotonin, and acetylcholine and histamine. Now, generally, all antipsychotics block dopamine receptors in varying degrees in the brain. Now, blockage in the mesolimbic pathway is said to relieve positive symptoms of schizophrenia, while blockage in the mesocortical pathway is said to relieve negative symptoms of schizophrenia. However, blockage in the tuberofundibular pathways are said to cause hormonal side effects, such as metabolic syndrome, hyperprolactinemia, and then blockage in the nigrostriatal pathways are said to cause movement disorders, most notably the secondary side effects. Now, atypical antipsychotics or the second generation antipsychotics, they generally show lower affinity for dopamine receptors. An exception of this particular statement could be risperidone. These antipsychotics, the second generation antipsychotics, like I said, they also block serotonin to a high degree. So lesser dopamine blockage and higher serotonin blockage, with of course the exception of risperidone. Now, other antipsychotics that can also have partial agonism properties are antipsychotics such as aripiprazole. These antipsychotics, aripiprazole is meant to have partial agonism at D2 receptors. But the property can make such patients that use this medication prone to things like gambling or addiction for certain things. So this is the dopamine pathway in the brain. That's the mesolimbic, mesocortical, neurosocial, and the pathway. Now, the side effects of antipsychotics. Now, this is a table itemizing the side effects of antipsychotics using plus signs. Now, chlorpromazine, like you can see in this table, has 1+ for another side effects, or tallipes can also included. Now, however, this same chlorpromazine has 3 pluses for dyslipidemia. In other words, it is 3 times more likely to cause dyslipidemia than it is to cause another side effects. On the other hand, haloperidol is more likely to cause another side effects, given the 3 pluses it got there, and the 1+, and less likely to cause dyslipidemia that is given the 1+ it does. I will not bore you by talking extensively on this particular table. I believe you can look at it at your convenience later. Now, side effects of antipsychotics. This is also on that table, itemizing the same thing, but involving mostly a narrower group of antipsychotics. Now, factors to consider when choosing your antipsychotics. Now, to choose your antipsychotics for a patient, some factors you have to bear in mind. The very first factor to bear in mind, like we all know in medical practices, is their diagnosis. Now, if, for example, your diagnosis is bipolar affective disorder, now it will be safer to choose the most stabilizing antipsychotic, such as olanzapine or quetiapine, as your antipsychotic for your patient. That is, if your diagnosis is bipolar affective disorder. Similarly, for a patient who is being managed for treatment-resistant schizophrenia, the WHO guidelines and NICE guidelines declare that clozapine is usually the drug of choice for treatment-resistant schizophrenia. In a similar version, for patients with hebephrenic schizophrenia, like most people with psychiatric knowledge would know, has more of negative symptoms than positive symptoms. Now, in such a patient, like we mentioned before, atypical antipsychotics are usually better for negative symptoms of schizophrenia. So, in such a patient, it would be better to choose an atypical antipsychotic as your first choice of antipsychotic rather than a typical or third-generation antipsychotics. Now, adherence. Adherence can given the fact that patients who do not adhere to medications might need to take. Now, for psychiatric treatment, we call depot antipsychotics. Lipophilic that when injected into the for a fortnight or a month, as the case may be, every fortnight, every month, depending on the manufacturer's stipulations. Now, these antipsychotics known as depot antipsychotics will also be used where adherence is poor, that is where your patient is unlikely to accept tablets. We have a number of depot antipsychotics in psychiatric practice. Particularly in this environment, we have fluphenazine, we have flupentazole. These are the major ones, but in more advanced world, we have haloperidol, we have haloperidol depot, we have aripiprazole depot, amongst other antipsychotic depots. Now, the age of the patient. NICE guidelines stipulate that use of second-generation antipsychotics is usually first line for young patients. Now, for the word young, we are referring to growing people. Now, why do we not use first-generation antipsychotics like haloperidol for this group of people, or trafulazine for this group of people? Now, first-generation antipsychotics are known to cause hyperprolactinemia. And now these patients are still growing. Now, hyperprolactinemia can cause early fusion of the bone epiphysis, such retarding the growth of this or suddenly ending the growth of these young patients. And as such, first-generation antipsychotics are usually not used as first line for growing people. These are the first choice for this group of patients. Also for elderly patients. Now, for elderly patients, first-generation antipsychotics can predispose them to osteoporosis, like we all know, an old lady in her 70s or so could get her bones could get so eroded that she could have a fall and have fracture of the femur and things like that. In similarly, I will not bore you by explaining what metabolic syndrome is. I believe most of my audience are doctors. Venous thromboembolism also and stroke are side effects, of this second generation antipsychotics. So generally for elderly people, it is advised that whatever you choose, you start slow and you go slow. You keep the side effect profile of the particular medication in mind, and then you bear in mind that your patient might take this medication for long, and then monitor the long-term and short-term side effects as necessary. Now, financial status. Earlier in the presentation, I mentioned that second-generation antipsychotics are more expensive. So you have to think about your patient's pocket when prescribing. Now, these medications, as second generation, they are more expensive, and when your patient afford them, and you consider the side effects, and your patient can tolerate short-term antipsychotics, and then the treatment is
Hello, we can't hear him again. I don't know that I'm the only one, please.
I cannot hear either.
I can hear him too.
It seems to be a network problem. Let's give him a few seconds to fix it up. Let's just bear with him a bit.
Yeah,
Okay.
I cannot hear him. Okay. Thank you.
It's okay, we're looking.
Sorry for that brief interruption. Now, still on factors to consider when choosing your antipsychotic. I am now talking about comorbid diagnosis. Good hypertension, diabetes, seizure disorder, febrile illnesses, to mention a few. Now, most antipsychotics, especially the second generation antipsychotics, with the exception of a few like antipsychotics, can cause metabolic syndrome. I've mentioned this fact before. And these antipsychotics are better avoided in diabetes mellitus patients and in hypertension patients. So mostly in our once again, we are sorry for that brief interruption. Now, still on comorbid diagnosis, now talking about seizure disorders. Now, antipsychotics. Now, generally, all antipsychotics lower seizure ratio. However, their propensity to lower seizure ratio varies. The high potency third generation antipsychotics like haloperidol, these medications tend to have lower propensity to lower seizure ratio than the low potency third generation antipsychotics or the second generation antipsychotics. Now, these medications are often more preferable when treating seizure patients That is why you see most seizure patients being prescribed haloperidol. Another antipsychotic that some clinicians often prefer when treating seizure patients is risperidone. This is a medication that has a second-generation antipsychotic that has more properties of the first-generation antipsychotic than the second-generation antipsychotics. In other words, it has better propensity to block dopamine than to block serotonin receptors. So for patients with seizure disorder in this environment, high-potency first-generation antipsychotics are preferable. And first among them could be haloperidol. Now, for patients with febrile illnesses, in this group of patients, it's usually good to weigh the benefits against the risk. Now, if, for example, your patient is so uncooperative with nursing care, is generally unsafe for fellow patients and relatives and even medical team, now it's advised that such a patient might need to continue his antipsychotic during his febrile illness. Now, for such patients, it's often preferable to also use low-potency, high-potency antipsychotics of the first generation, such as haloperidol. I'm not saying particularly that this is a past week. Some clinicians might prefer otherwise, but this medication is relatively less risky in the sense that when these patients are having febrile illnesses, they are less likely to be predisposed to.
Seems the problem is still repeating itself.
I was on factors.
Hello, sir. Just you seem to have network problem, but just try to run up if possible, in the next 10 minutes, so that we can take questions.
Okay. So chronic liver disease and chronic kidney disease. Now, for these particular patients, antipsychotics are best avoided, except in mild to moderate cases where the benefits outweigh the risk. For this group of patients, amisulpride or fucoid are preferred for chronic liver disease patients. That is where the benefits outweigh the risk for mild to moderate cases. Similarly, low dose haloperidol or 5 mg of olanzapine might be tried for chronic kidney diseases, also where the benefits outweighs the risk in mild to moderate kidney diseases. Now, how about patients with high BMI? Now, this group of patients, for them, it's good to avoid low-potency antipsychotics, first-generation antipsychotics such as chlorpromazine, and second-generation antipsychotics such as olanzapine, chlorpromazine, and quetiapine. Now, these are known for their higher propensity to cause weight gain. Now, preferred for these patients are higher potency first-generation antipsychotics such as haloperidol, fluphenazine, and trifluperazine. Similarly, second-generation antipsychotics such as aripiprazole or ciprazole can also be used in these patients because, like these higher potency first-generation antipsychotics, they have lesser propensity to cause weight gain. Now, this is a table showing the likelihood of weight gain among antipsychotics. Now, how about patients with insomnia? Now, for this group of patients, antipsychotics that block serotonin receptors and serotonin 2C receptors and histamine receptors are usually preferred. These antipsychotics include antipsychotics like chlorpromazine, olanzapine, quetiapine, and ziprasidone. Now, of course, you have to also weigh other properties, other characteristics of your patient, as these medications also have other side effects they tend to come with. Now, it's also good to think about the medications that are prescribed for your patients. before they come to see you as a psychiatrist. Now, I will just mention that some antipsychotics tend to increase the curative interval. Antipsychotics such as ciprofloxacin and erythromycin need to be used with caution in patients who take antipsychotics that increase the curative interval. You will see that in the table atomizing side effects of antipsychotics. Now, these medications such as albuterol and ziprasidone, they tend to increase curative interval, and as such, they cause synergy when prescribed together with ciprofloxacin and erythromycin, or medications such as even amiodarone. This is especially true with cardiac patients. How about pregnancy and breastfeeding patients? Now, while prescribing in pregnancy, like we all know, is good at the effect of the drug and the drug passage through the placenta. Now, generally, medications like risperidone, which is very common in our environment, is teratogenic and is contraindicated in early pregnancy. It is stipulated that the drug should not be prescribed earlier than 20 weeks of gestation. However, medications like olanzapine and However, medications like olanzapine and quetiapine are considered safer in pregnancy. These medications as such are used much in the UK in the NHS practice. A side effect of the two of them, however, is gestational diabetes mellitus. In our environment, however, some psychiatrists have often used albuterol and risperidone, that is the high potency first-generation antipsychotics, for short term among pregnancy patients without much mishap or side effects. Now, contraindications of antipsychotics. Among such, some contraindications of antipsychotics include things like severe weight loss, where antipsychotics is contraindicated, of course, due to things like refeeding syndrome. Antipsychotics can potentiate such a side effect by increasing appetite and causing weight gain. Dehydrated patients need to be rehydrated before antipsychotics are prescribed. Severely anemic patients are also not supposed to use antipsychotics. This is because of things like epistatic hypotension and the risk of causing seizures in severe anemia. All these of which we know antipsychotics are guilty of. Now, previous history of allergy. Now, when a patient has a previous history of allergy to an antipsychotic or a particular group of antipsychotics, usually advise to withhold such an antipsychotic or group of antipsychotics from such a patient. Severe cardiac abnormalities. Now, like I said before, patients with cardiac abnormalities be prescribed antipsychotics that can prolong curative interval. I've mentioned the reason before. Now, narrow angle glaucoma is also a contraindication for antipsychotics, especially antipsychotics with high anticholinergic effects such as chlorpromazine. I will not explain, I don't have much time to explain that due to the limited time available at the moment. Now, myasthenia gravis is also a contraindication of antipsychotics that have high cholinergic property, high anticholinergic property. Now, I'll take the first case witness before I conclude. The first, second, and third, and fourth case witness before I conclude. Now, case witness 1. Now, Ms. A is a 55-year-old woman. She's a non-diabetic hypertensive. She has been diagnosed with bipolar affective disorder, current episode, manic, and she also had bilateral catheter surgeries and has also been diagnosed with diabetic and hypertensive retinopathies. She's on sodium valproate, and the question here is, what is your choice of antipsychotic? Now, this is a real patient in our practice are picked as this case witness. Now, the items to consider in these particular patients, first is a non-diabetic and hypertensive. Second is intermittent bipolar affective disorder. Now, as a non-diabetic and hypertensive patient, these patients need to avoid medication that cause metabolic syndrome or have high propensity of causing metabolic syndrome. In a similar vein, this patient has bipolar affective disorder and currently manic. Now, it's advised that this patient should get an antipsychotic that has a mood stabilizing property. Similarly, these patients, diabetic and hypertensive retinopathy history makes him a bad candidate for antipsychotic with anticholinergic properties. Now, generally, then the only medication in our environment this patient can actually take is aripiprazole. Now, aripiprazole has less propensity to cause similar side effects. It has less propensity to cause metabolic syndrome. It's a mood stabilizing psychotic, and it has lesser anticholinergic property. Now, case beginner 2. Ms. B is a 16-year-old girl found wandering on the streets with poor personal hygiene. Mental state examination of this patient revealed that she had pathos laughter and was irrelevant in speech. Relatives reported that she had lost some weight and that illness dates back to 2 years ago. The evidence of photophonic schizophrenia has been made. Now, what is the choice of antipsychotic and why? Now, for this particular patient, she's 16 years old, and as such, a first generation antipsychotic is the first choice of antipsychotic, such that such that the patient's growth should not be retarded with side effects such as hyperprolactinemia. Medication in terms of schizophrenia, making second generation antipsychotics a more suitable type of antipsychotic to prescribe. Similarly, this patient also has some weight loss, and it might not be bad to put a medication that will increase her appetite and make her eat a little bit more and gain more weight. That is if she's not cachectic. Now, for medication that fulfill all these criteria now is, for me, I chose olanzapine for this patient. Now, don't get me wrong, some psychiatrists could choose another second generation antipsychotic for this particular patient. But having itemized my points I considered in this patient, olanzapine fits as a particular antipsychotic that gives all the benefits this patient requires for improvement. Now, Mr. C is a 27-year-old newly married poor farmer. He's a known epileptic on carbamazepine. He has often had seizures, but recently he complained of auditory hallucinations, and his relatives reported persecutory delusions and occasional irrelevant speech. Now, these symptoms occur a day or two after the seizures, and they are bad after he has stayed without the seizures. The diagnosis of interictal psychosis has been made, and his carbamazepine dose has been increased. Now, what is the choice of antipsychotic and why? In this particular patient, there might be more than one or two antipsychotic choice for this particular patient. However, personally, issues to consider are first, this patient is a poor farmer, and as such, third generation antipsychotic might promote more adherence for him, as his pocket is not deep enough to afford third generation antipsychotics. He has seizures, and as such, he will need high potency third generation antipsychotics, which have lesser potency to reduce seizure threshold. He also have positive symptoms of schizophrenia, which are more likely to resolve better with third generation antipsychotics. So for these patients, I chose haloperidol as his antipsychotic. Of course, we will see bear in mind that long-term, short-term, and long-term side effects will be monitored, such that patients does not develop severe side effects such as dyskinesia. So I'll go ahead to talk about case witness 4, the final case witness.
Please, sorry, sir, if you wouldn't mind, maybe we can take the 3 and entertain question in a few minutes.
The first is actually more important than the first. I think I should have put it as case
All right,
once.
all right. It's okay,
Yes,
sir. So let's take it in the next 2 minutes, if possible, so that we can take the second presentation. Thank you.
Yes, sir. So Mr. D is a 22-year-old undergraduate. He presented with talkativeness, physical aggression, and poor sleep. Now, you met him at A and B shouting and disturbing. He's said to be using alcohol and cannabis regularly. The evidence of substance-induced psychosis has been made. Now, what is the actual antipsychotic to calm this patient down? Now, for these patients, I will take it that verbal de-escalation has been tried and has already failed as he's still shouting and disturbing. Now, there are some items to consider. First, you have to take a parenteral antipsychotic, that is an IM antipsychotic. And there are 3 of such antipsychotics in our environment at the moment. We have the IM haloperidol, IM chlorpromazine, and IM olanzapine. Now, this particular patient uses alcohol. Now, IM chlorpromazine and IM olanzapine are known to lower seizure threshold, the same way that alcohol lowers seizure threshold. Now, these 2 medications will not be a choice for this our patient. Now, it's advised that this patient is given down. So, in conclusion, antipsychotics are mostly prescribed when our thoughts and emotions are so disturbed that we lose touch with reality. They occur in different types and groups and have different pharmacodynamic and pharmacokinetic properties. And as such, certain biological, social, and psychological factors need to be considered to choose the right for effective patient management. These are my references. Thank you.
Okay, thank you very much, sir. It was a wonderful presentation from Dr. Chimbo Chijioke, a consultant psychiatrist with FMC Jalingo. You know, the topic is quite broad, and even if we give him 3 hours, he will still talking. And at the end of the time, he won't be able to cover justice to the topic. He has summarized a lot of things. He brought out, main point, ask question or make some contributions. Thank you very much. And on the chat, I can see questions there already. But I think the members can ask first, then later our presenter can attend to the questions on the open. Let's make that very snappy. Are we together? Hello?
Yes, we're together.
All right. So if there's question, please ask. But why we're still thinking of the questions to ask, maybe let me read out what our father, Dr. Ebenezer Apaki, the question he asked. 1, he said, what particular age, in bracket, young people for which you will not consider first-generation antipsychotics? That is the first question he asked. And the second question, he said, on the average, how much does it cost to treat a person with second-generation antipsychotic for a month? Our presenter, I believe you took note of those 2 questions.
So, taking the first question, at what age do you consider not prescribing first-generation antipsychotics to patients? Now, what NICE guidelines actually said is that every individual who is growing, who needs to take an antipsychotic, should take second generation antipsychotic as first choice. Now, it's not a hard of, it's not particularly binding. If, for example, you are going to prescribe the antipsychotic for just a week or two, this law might not necessarily be binding on you. But if your patient has something that is chronic, for example, hebephylic schizophrenia, where antipsychotic use is going to last for quite several years, if this patient is still growing, if, for example, even if he's 17, 18, if you just consider that he's still growing, that your patient has not completed growth, that is a fact to consider, not necessarily the age, that your patient is still growing. In other words, bony epiphyses have not closed. Such a patient should receive a second generation antipsychotic and not a third generation antipsychotic. I've already explained the reasons. Thank you. Now, the second question. How much does it cost in a month to treat a patient with second generation antipsychotics? Now, second generation antipsychotics in our environment differ in types and in costs. I will just mention the few of them that are available in this environment. We have risperidone, we have olanzapine, we have aripiprazole, we have quetiapine. I don't know if there are any other particular ones that are prescribed outside this hospital, but these are the major ones we prescribe in this hospital. Now, for each of these medications, their cost differ. The cost of each of these medications differ. Now, I think I'm safe to say that the most expensive among them should be the aripiprazole. Why? Mostly because of its generally safe side effect profile. Now, this aripiprazole, like I am made to understand by the dealers in town, the cost for 10 milligrams of aripiprazole per night for 30 days, that is 1 month, as you mentioned, is 7,500 naira. That is for this aripiprazole. Now, risperidone is an antipsychotic that is quite cheaper than these other 4 antipsychotics I mentioned. Risperidone, I don't think it can cost more than 4,500 for a 30-day course of maybe 2 milligrams. That will last for 1 month. So from 4,500 naira of risperidone to 7,500 naira of aripiprazole. That should be the range of second generation antipsychotic costs in our environment for a 1 month course.
Okay, I think the answer he has given has made it clearer to all of us. So I wish we can clap for him, but since it's a virtual meeting, even if I say we should clap, our presenter wouldn't hear that. So we thank you very much, Dr. Chimbo Chijioke, for that wonderful presentation. And to those of us who still have questions, please, you can jot it down, and later you can ask. And for the sake of time, we are going to the second presentation, which is identifying and management of congenital tallipes equinovarus. And that will be taken by Dr. Nkinyam Gilbert, a consultant orthopedics, also with the FMC Jalingo. Thank you very much, sir. You have the floor. Let's try to manage our time so that we can finish the presentation, if possible, in the next 45 minutes and entertain questions. Thank you so much, sir. You have the floor. Our second presenter, Dr. Gilbert, the floor is yours. Sorry for the technical glitch. That will be sorted out in a short while.
Hello, colleagues. Good afternoon, colleagues.
Good afternoon.
Good afternoon. Am I being heard?
Loud and clear.
Yes, we can hear you, sir.
Yes, we can hear.
Okay. Good afternoon. I am Dr. Gilbert Nkinyam, consultant orthopedic surgeon here in FMC Jalingo. I'll be presenting management of congenital tallipes equinovarus. I usually like to do this practically, but since we are on Zoom, let's see how far we can go. Next slide, please. Hello. Yes, these
are with you.
Yes, these are just photographs showing what we are going to do. Dr. Bright, please make it snappy. I'm not going to waste so much time. Get to the next slide. This is a posterior view of a child with bilateral tallipes equinovarus. Let's go. We are going to attempt the discussion using this outline: introduction, pathology, management, complications, follow-up, conclusion, and references. Let's go. Next slide, please. Congenital tallipes equinovarus is what we also know as idiopathic clubfoot. It is just a form of clubfoot, and this is the idiopathic type. It is a deformity of the foot that makes the foot to be plantar flexed, inverted, and adducted. This is the most common congenital foot condition that we find in orthopedics. It represents about 9% of foot defects seen in orthopedic practice. Next slide, please. Next slide, please. The incidence varies across geographical locations and races. About 1.2 in Uganda and Ghana, 2.0 in Malawi, 2.7 in Papua New Guinea, and up to 3.4 in Nigeria. The male to female ratio is 2:1, and 30 to 50% of cases are bilateral. Next slide. If there's no history of such a condition in a family, the chance of developing a history that a sibling, a child is already having this condition, the next child that is being born has up to 10% of chances being born with this condition. Next slide. The cause of this condition is actually unknown. However, like we all know, conditions that are unknown etiology have some theories. Next slide, please. These theories are varied and many, but I decided to put a few. And in this few, we will see the causes that could be mechanical, in utero and outside the uterus, and then some causes that may be intrinsic to the components that form the tissues that make up the foot. So it will be wise for us. I've already categorized these theories into two, because as we'll see in the next slides following, where we'll be talking about the types of clubfoot, we'll see that those that have causes from outside the uterus or inside the uterus that are blocking mechanical in a way cause very subtle postural types that are easily managed compared to those that have causes that are intrinsic to the tissues. So we have the theories as listed, and among these, one of the mechanical blocks that are external to the uterus is the dunes theory, which is you can liken it to any abdominal mass that is constricting on the uterus. Next slide, please. This one is different from the last theory here, which is the packaging theory, in which the masses are actually competing with the fetus in utero. Next slide. So talking about the types of idiopathic clubfoot that we have the postural or the extrinsic, like I was trying to explain. If the masses that are competing with these fetus are not found within the tissues, the type that we have is called the postural type. And this one is very easy to manage compared to the fixed or intrinsic type, where the pathology is resident in the tissues of the foot. Next slide, please. This is just a normal child. You look at the picture, you see the feet well disposed and aligned. As a doctor, a mother or a caregiver can just be concerned and call you to check on the feet of the child. What we do, and we usually say it is a safe way to screen, is to try to push the sole of the foot towards the shin of the leg and see whether the dorsum of that foot can touch the shin. Next slide, please, so that you demonstrate what I mean. So once you are called upon and there is somebody is thinking that the child may have a clubfoot, the safe way to check whether this child really has a clubfoot or not is to try to push like the presenter has pushed this 2 feet here. You can see that the dorsum is actually touching the shin of the feet. Next slide. Once you have this, the child may have another foot condition, but it is not likely to be a congenital tallipes equinovarus. This still demonstrates the fact that I'm trying to portray. Next slide. Just to talk of relevant anatomy, we know the foot is that part of the lower limb that is distal to the ankle joint. Here, the ankle joint is where the tibia and the fibula articulate with the talus. Next slide. Going deeper to the structures, the main muscles and tendons that actually contribute to this deformity are these three muscles and tendons on the medial side of the foot. You have the tibialis posterior, the flexor digitorum longus, and the flexor hallucis longus. You can commonly remember them as Tom, Dick, and Harry. Tom for tibialis posterior, Dick for the digitorum longus, and the Harry for the hallucis longus. Next slide. It also just shows you the bones of the foot and some of the ligaments that are very important in this pathology. Of very paramount importance is the talus and the navicular. If you look at the slide, you see T is for talus and the N is for the navicular. This is how a normal foot looks like. Next slide. Just to buttress the fact, because very soon we'll see where the deformities actually occur. It is unfortunate that we don't have, I can't give the breakdown, but here the foot has been divided into 3 parts: the forefoot, the midfoot, and the hindfoot. And when we go further, we'll see that that is where these deformities actually occur. This is still a normal foot, and very soon we'll get into seeing what happens when the abnormality sets in. Next slide, please. On the left is still the bones of a normal foot. Meanwhile, on the right, there is a distortion in the setting of clubfoot pathology. If you look at the picture on the left, you will see some lines passing through bones. These lines can be used as a guide, especially when you do an X-ray. It can be used as a guide to know where the severity of the foot is. On the left is a normal foot disposition, bones of the foot. While on the right, if you look at the left, there is the talus and there is the navicular. This talus articulates with the navicular. But in the clubfoot on the right side, you will now see that there is a subluxation, even leading to near dislocation of the talus, of the talonavicular joint. And that is where that pathology lies. If you go back to where I showed the tendons that pass on the medial side, there's a very important tendon there. Although there are three of them, there's one, the tibialis posterior. That is the one that is very much implicated in the pathology of the clubfoot because it inserts into a myriad of those talab bones that you have there, all those bones, the navicular, the cuneiform bones, the heads of the metatarsals, and there is even a recurrent branch that attaches to the calcaneum. Let's go, next slide, please. These, if you look at on the medial side now, where those structures actually are, where they pass, you will now see that because of the contracture of those structures on the medial side, the forefoot is kind of being carried towards the medial side. And depending on the degree of tiredness or contraction of these tissues on the medial side, the medial side of the forefoot can actually get to be opposing or touching the medial malleolus. All this happens depending on the degree of the pathology that you are looking at. Next slide, please. This just shows you a picture of how these children present to us. This is a child, a girl, 6-year-old, with bilateral idiopathic clubfoot. This is an anterior photograph. Next slide. It's the same child with the picture taken from behind. She's 6 years old, and you can see she's already walking, and we'll see what such behavior could present in terms of other features that accompany clubfoot. Next slide, please. This one is a left unilateral clubfoot, just to buttress how these children appear. And depending on the degree of the contractures on the medial side, the foot can get to any length. Next slide. You can see the rotation of this foot is almost very severe compared to the other ones that we have seen. Next. When these children present in the clinic, they present in the clubfoot clinic, you need to take a detailed history and examine them appropriately. In the history, you are interested in the pregnancy history of the mother. You want to find out whether it was a twin pregnancy, whether the woman was diagnosed of other conditions like fibroids and so on. And especially for our primogravidas, because the uterus is very tight, it is very possible that for first-timers, the child will come out with such deformities. So a detailed history actually will give some clues on why this happened. Women that were treated for oligohydramnios during pregnancy and so on will likely present with children that have such deformities, because there's competition for the space that this child also occupies. then you need to find out whether this child has other deformities and so on. Then try to probe into the family history. Just like we said, for a family that already has a child that has this condition, the next delivery, a child, it has up to 10% chances of having clubfoot. Then in the physical examination, you need to examine this child thoroughly from head to toe. For the feet, where the pathology is, you want to identify and characterize the deformities that are present. As we'll see shortly, there are some classical deformities that such children come with. And then there is this factor associations that you want to find out whether the child also has. Look at the vertebrae, anorectal malformations, cardiac, tracheoesophageal deformities, and renal in addition to the limb deformities that you have. Next slide, please. So classically, when a child presents, there are these deformities that occur, like we are trying to explain the forefoot, the midfoot, the hindfoot. Classically, in the forefoot, the child has this adduction and supination of that forefoot. And in the midfoot, there is an exaggeration of the longitudinal arch. We call it cavus. So every normal person has a longitudinal arch, but when it becomes exaggerated, it's no longer normal, it's cavus. Then the heel, which is the hindfoot, the calcaneum will be in varus. Sorry, we are not, these things are usually very practical when you are talking about them and then you demonstrate them. Then the ankle is in fixed plantar flexion, some fixed plantar flexion, more than the normal. Of course, the foot is not in plantar flexion, but it is fixed in plantar flexion, and that's the equinovarus. It occurs at the ankle joint. The child may also have other features. The tibia may be internally rotated in what we call internal tibial torsion. The calf may be so atrophic and the muscles will be so small compared to the other ones. We'll see some photographs when we move further just to portray the fact. Then there may be callosities for a child that has started walking with this deformity without being corrected. They may develop callosities, there may be hyperpigmentations, ulcers, and a lot more features. Next slide, please. This is a child that presented, this child was 10 years old. You can see on the lateral side, you can see that hard patch there, that's the callosity. And if you look at the foot, you see some color changes and some areas of hyperpigmentations. Next slide, please. This child, we saw the picture of, this is a unilateral left club foot. If you look at it critically, you see that that left lower limb is far much smaller than the right. Okay, and like just as we have just said, there are atrophic calf muscles. Of course, if the foot is not in its normal position, since the child is growing and the foot is not in its normal position, it is bound to, the growth is bound to be retarded. And this is what results in such a child. Next slide, please. It's the same child with the picture from behind. Next slide. There are various scoring systems that we use just to measure the severity of the clubfoot that the patient is presenting with. We actually consider scores from the hindfoot and then the midfoot. Pirani scoring system is a very simple scoring system that we use and grades the deformities that we look out for from 0, 0.5 to 1, depending on whether the 0 is normal, 0.5 moderately abnormal, and 1 is severely abnormal. So there are 3 scores for the midfoot score and 3 scores for the hindfoot score. And you can see that the least score you can have is 0, while the highest is 6 when you're using the Pirani score. For the next slide, for the midfoot score, you look at the curved lateral border, you score it, depending on the severity, it could be 0, it could be 0.5 up to 1. The medial crease and the thaler head. Like I said, these are usually practical things that we want to demonstrate. But if we finish and you look at this slide critically, you may be able to make some sense out of it. Next slide, please. The next slide will show the hind foot scores. Here you look at the posterior crease, you grade it to the rigid equinus, and then the empty heel, you grade it. You can look at the slide afterward and make some sense out of it. Next slide, please. Actually, for diagnosing a clubfoot, a congenital tallipes equinovarus, it's actually clinical. Once you have been able to make out these deformities and so on with tallying with your good history and examination, you are good to go. The next thing you need to do is to take clinical photographs when you have made your diagnosis. These clinical photographs will also help you, because as you correct and make progress, you see where you are. Then kind of also encourage the caregivers, because anytime they come for manipulation and casting, they will look at where it started and look at where the situation currently is. And it actually encourages them to be coming since they see that progress is being made. X-rays are done just for academic purposes, and we may not want to dwell deeply into that. Of course, you take X-rays in AP and lateral views, and there are angles that you calculate, just like I showed somewhere up. There were some lines, horizontal lines through the mid-axis of calcaneum, talus, and then the first metatarsals. Those ones, you can measure them and then make some sense out of it, but it's purely academics. Next slide is you can use it for research and then get more papers and grow in your academic career. These are the lines I'm talking about. There is these lines pass through the talus, through the calcaneum, through the first metatarsal. So you have what is called this is an AP view. So you can measure the talo-calcaneal angle in this AP view, and you can measure the talo first metatarsal angle in this AP view. If you look at the critically, you see A, you see B. So the A is the talo-calcaneal angle, B is the talo first metatarsal angle. Next slide. So there are values. Then this one is it's already a clubfoot, and you can see that those angles are distorted. So once you have this kind of picture, you get some angles that are smaller than what you need. Next slide. Next slide is still another illustration. So here you have the normal of the angles, and then for CTEV, you see the angles as stated. Next slide. This one is a lateral view. Next slide. Lateral view, you still measure those angles, and you see that they're different. Here you have the range, normal range, and then you have the CTEV range. Next slide. You can actually add the talo-calcaneal and in the AP and the lateral views, and then measure them to form what we call the talo-calcaneal index. From there, you'll be able to know what your prognosis may be. If the angles are more than 40, between 20 to 40 or less than 20, you know you can prognosticate as stated in the slide. Next slide, please. What are the differential diagnoses when you see a patient with congenital tallipes equinovarus? Like we have said, when you mention congenital tallipes equinovarus, you are saying that you are talking about idiopathic clubfoot, which is different from other clubfoot. So the differential diagnosis will be just other differential or other types of clubfoot. And you can actually broadly classify them into acquired or the syndromic clubfoot. The acquired clubfoot you see in children that have cerebral palsy, for example, children that have poliomyelitis, for example, children who have suffered some contractures and then the foot became like a club. So those are acquired. Meanwhile, for syndromic, you have various syndromes like arthrogryposis multiplex congenita, you have Ehlers-Danlos syndrome can make the feet to turn to be clubbed, but it doesn't mean that they are CTEV. Next slide. Yes, this is a child that we operated a few months ago with an acquired. This child has cerebral palsy. It's a child with the unilateral left club foot. This one is secondary to cerebral palsy. This is an anterior view. Next slide. Next slide will show you the posterior view of this child. So this is an example of an acquired club foot. Like we have said, polio can also produce such. Next slide. This is one of the very strangest syndromic that I have met since my practice here in FMC. This child has arthrogryposis multiplex congenital. This one is a very severe form. I've never seen this. I just saw this here, but I've seen many AMCs, but this one was so terrible. Next slide, you see what we were able to get to at 4 weeks later. This from the front. Another next slide, please. Show you from the back. Then we continued. Just that we are still manipulating and we have not yet reached the final destination. Next slide. How do you treat? The goal of treatment is simple. We want to achieve a food that is plantigrade, looking like the normal food, a food that is soft, supple, painless, well-functioning, and can adequately be put into a shoe. So we need to have a food that the mother can go to the market and buy shoes for the child. That is usually our goal. You can agree with me that if you are working with an awkward food, before you know, there will be pain, because that's not how that food is supposed to be. You'll be putting pressure on many unnecessary areas of the food. Next slide, please. What we do here, which is the standard worldwide, is we use the Ponseti technique of manipulation. We do the manipulation and casting every week. So we start, it is good to start very early, maybe first week that the child is born, but we have cases that present, some present immediately, some present maybe you can say early, some late, and then some very, very, very late, which we call neglected club feet. So what do we do? There is an acronym that we follow when doing this manipulation and casting. It is commonly remembered as CAVE, C-A-V-E, which stands for cavus, adductus, varus, equinovarus. Then in the end, we may just cut the Achilles tendon. It's a clinic procedure. You just cut it to achieve good dorsiflexion of the foot. What happens in the cavus? The cavus, like we said, is the exaggerated longitudinal arch of the foot, so producing the cavus. Here, the forefoot and the hind foot are not aligned. So in the first manipulation, usually our aim is to align the forefoot to the hind foot. What that we simply do by raising the first metatarsal in supination. We call it first metatarsal supination stretch. You do it like that and you cast it. Usually, as you are doing it like that, you are manipulating thumb is on the thala head to keep it in that raised and supinated form, and it is casted. Usually 1 or 2 casts in that position will align the forefoot and the hind foot. The next thing is you go for the adductus. So you are trying to abduct, because the foot is in adduction. You are trying to abduct, still with the talus as the fulcrum. The manipulating hand now is on the first, on the thumb and the metatarsal, and you try to abduct. Those movements are done serially until the foot is able to reach an abduction angle of 60 to 70%. Usually, when this adduction is being corrected, the varus too follows it, because the bones of the feet are interdependent. They don't work individually. As you are trying to do one, they also coerce other bones to fall in place. So by the time you are correcting the adduction, the varus too is being corrected, and now you are left with the equinovarus. Then you gently start dorsiflexing. Anytime you do this, you keep it in the corrected position and apply a cast from the toes to the groin with the knee in flexion, 90 degrees of flexion. Next slide, please. Next slide. Next slide, please. Yeah, this just shows, you can see the two hands are there. One is, the thumb is stabilizing that foot from the head of the talus, while the other hand is gently manipulating the foot. Here, what the clinician is actually doing here is abducting this foot. So he's trying to correct the abduction, which means that he has already corrected the cables. Now he's trying to correct the abduction. Once you do these manipulations for 1 to 3 minutes, then you now cast in that position. The following week, you still come, do the same until you have achieved the angles that you want, and then you can say you have achieved correction. Next slide, please. When we do this, we apply the cast from the toes to the groin with the knee in 90 degrees. Why you put the knee in 90 degrees is you want to relax the gastrocnemius muscles so that your correction will stay in place. Next slide. You can see from left to right the various positions that the club foot usually is being corrected. As you progress from week 1 to week 2 to week 3 to week 4, they achieve the gains you make show in the cast that you put. You can see the last cast there. You can see the foot is no longer in plantar flexion. It's in somewhat some dorsiflexion. And then in abduction, it is no longer facing medially, it is facing outwards in abduction. Next slide, please. Once you have achieved the correction, the next thing is the maintenance phase. Because if you don't maintain what you have corrected, the next thing is that there is recurrence. Your deformities start coming back. So what do? We use what we call abduction foot orthosis. There are different types of them. But what we use here in Jalingo is the miracle feet braces. You have Dennis Brown braces, you have Stenbeck foot abduction braces, and a whole lot of them. But what we use here is the miracle feet braces. When you start wearing these braces, usually the child wears these braces the first 3 months. The child wears these braces throughout the day, 24 hours, only removes them when the child is taking the bath, and that's all. After that, the shoes are worn. So for the first 3 months, almost all the time, these shoes are worn. Then from the next 3 months, it's expected that the child starts maybe sitting, maybe, and so on. Now you want to be wearing these shoes at night. And then during the day, if the child is sleeping, you will now wear these shoes. But when the child is awake, there are actually shoes that you can wear during this time that the child is awake, from 3 months upward. Next slide. And you wear these shoes until the child is 5 years. So these are the braces that we have. The red one is the bar, and then the brownish one up there are the shoes that are worn. Next slide, please. When you wear them, they look like this. Next slide. Then this is how the child looks like. So the child wears these braces for the first 3 months, wears them for 24 hours, subsequently wears them for 14 to 16 hours throughout the night, and then just when he's sleeping during the day. Next slide. This one is another brace, but we don't use this one here. This is the Dennis Brown brace. Next slide, please. Ideally, we have what we call the CTEV shoes. We don't have them here. I will tell you what we use when the child is not wearing the shoes during the day because he wants to be crawling or walking around and so on. If you look on your left, you see how the normal shoe is with the heel, the aspect. On your right, you see a kind of shoe with a straight medial aspect, the sole is very flat, and then there is like a wedge towards the lateral side. All these are in a way to prevent any recurrence when the child is wearing this kind of shoe. We don't have them here, but what we do is when we have corrected and the child is in that period where he's crawling or standing or walking, we now tell the parents to buy a boot that is a little bit just above the ankle, and you can wear the right side on the left side and the left on the right. That also kind of tries to maintain what we have achieved during the day. Then at night, you go back to the braces. Next slide. Another slide. This one just explains what I've already explained. Next slide, please. What are the complications when we manage these children? If abduction, total abduction has not been achieved, and you want to force the foot in dorsiflexion, you will break it at the mid-tarsal joint, and you will result in what we call the rocker bottom foot. At times, the feet can actually be laterally rotated, and you find the child walking up awkwardly like that because of the, I call it, is it overzealous manipulation that has occurred? At times it happens, and then pressure sores actually occur when the casts that are usually used may be tight, or there are pressure points that are applied by the technician. Next slide, please. This is just a photograph of a child with the rocker bottom deformity. Like I've explained, it can occur. Next slide. When the patient comes in very late, patient comes in 6 years and above, ideally we actually achieve manipulation and casting that results in total correction in children that are up to about 3-4 years, 3-4 years, at times even 5 years. By the time the child is 6 years and above, or is even more, is no longer a child, they actually come. You can't do this manipulation and go away with it. You must operate. And there are some cases that relapse, become so recalcitrant that you cannot just manipulate and go away with it. So those are the instances where we operate. Next slide. And what do we do? There are basically 3 things that we can do. We have what we call the soft tissue procedures, the bony procedures, and the combined procedures. These procedures are usually done depending on the age of the child and the nature of the tissues that are in that foot. You can't do some procedures for less than 3-year-old. You can't do some for less than 6-month-olds, and so on and so forth. So for a very young child, you want to do soft tissue releases. For a child that is about 6 years and above, you may want to do some bony procedures in addition, and like that. Next slide. This one just shows a child that, one of the children that we operated. This is just shows you we are operating on the medial side, okay? And then the posterior on the Achilles tendon, and then the tissues of the medial side. Here, you just lengthen for a child that still has residual equinus, and then still has some adduction, which means that the lateral column is actually longer, or the tissues on the medial side are tight. You need to release them, lengthen them, and then the foot falls in place. Next slide. Next slide. Just shows you, next slide, go, next slide. As we go deeper, is the same thing. So end up with something like this, and then you now cast it. Cast it. Once the wound has healed and you remove your stitches and there's no wound breakdown, you now put it in the position that you'd actually want and cast it. And the next 6 to 8 weeks, the child start working on the cast, and then by 10 to 12 weeks, you remove it and the child is good to go. Next slide. Next slide. This is just when you have put your cast. Now, for other children, you can do, apart from the releases that you do posterior-medially, you can also do a calcaneocuboid fusion. When the lateral lateral column is very long, longer than the medial column. You may need to do a wedge osteotomy on that lateral side, remove part of the cuboid, remove part of the calcaneum, and then you fuse those two together. Next slide. This one, we did this just 2 weeks ago. So you can see we have already released the posterior aspect, and now we are on the lateral side, trying to now make a wedge through the cuboid and then the calcaneum. Next slide. We are still making the wedge. Next slide. If you look at it now, we have made the wedge and we have closed it. If you look at where those forceps are trying to expose, there is something like a staple that is trying to oppose part of the cuboid and then the calcaneum together to make it stay in one place so that it can fuse. Because if you don't, you may end up with non-union at that place and your foot will perpetually remain in with some residual deformities. Next slide, please. This one is not the one that we operated 2 weeks ago, but we operated this one like 6 months ago. You can see on the lateral side, you see an incision where part of that lateral column was approached and then fused. Next slide. This is the posterior view. Yeah, this is the posterior view, just showing the Achilles tendon was lengthened, and then we did that thing on the lateral side. Next slide, please. For a very old child, any child that has achieved that, whose feet have achieved maturity, you can do a triple arthrodesis. We don't do this for any child that is less than 12 years. The foot matures at 12 years, and if the child still has this deformity or comes as an adult, you can now do a triple arthrodesis because the foot has already matured. If you do this for a foot that is immature, you are sure that you have fixed that foot in that position and it will not grow. Next slide. For recalcitrant cases, we can use some of our gadgets, especially the Elizarov gadget. You can use it for recalcitrant cases. Next slide, you see a picture of how this gadget is. And then the correction is gradual. You just rotate it gradually, and it corrects. When it corrects, you now remove this device and the child is good to go. But we use it in very recalcitrant cases. Next slide. For the follow-up, once we have achieved maintenance, follow-up is very important because you want to be seeing this child. You want to know whether this child is using the braces well, whether this child is having some signs that recurrence is on the way. That too, you need to pick it up during follow-up and then address it. You don't leave it. You don't just say because you have corrected, that is all. No, the braces, the parents may not be using them well. So they come first 2 weeks after they have been discharged from the clinic. They come, you now see whether they are using them well and so on. If there are any issues, you address. Then the next time they're coming is 3 months later, where you change the regimen from 24 hours to 14 to 16 hours a day, like we have said. Then you see this child 3 monthly for the first 1 year, then 6 monthly for the next 4 years, making it 5 years. At that time, the rate at which the foot grows has reached its maximum. So the fear of recurrence is actually very low. You can now discontinue the braces, but you continue to see this child every year until this child is 12. At 12, like we have said, the foot is already matured. At that time, you are not afraid of any recurrence. Next slide. So in conclusion, congenital tallipes equinovarus is a very common and treatable condition. If you listen to patients or caregivers that come, they may attribute this to some kind of spiritual and all sorts of things. But usually we douse their tension and then we treat them and they go home happy. Early presentation offers the best chance of outcome. Thank you very much for your kind attention. And the references are there. You can look them up at your leisure time. Thank you, please.
We want to say a very big thank you to the presenter, Dr. Gilbert, for such a wonderful and educative presentation. In light of that, If we have any questions, we can indicate or we can put in the chat box so that you can respond appropriately. Thank you very much. I'll start by taking this comment in the chat box from Dr. Barrow, who says, "Wonderful presentation, sir. Good to know you can improvise materials and domesticate the treatment to still get results. More grace." Thank you very much, sir, for the comments. If you have any other questions, please indicate by a show of hands, or you can type them so that we can read them out. We also remember that there were some questions we were not taking from the first presentation. I think Dr. Akpake asked, on the average, how much does it cost to treat a person with second generation of antipsychotics for a month, and what particular ages, that's young people, for which we not consider first generation antipsychotics. Dr. Chijioke, Chimbo can also stand by to answer these questions when we are through with the questions for this. I can also see comments.
That has been answered already. That has been answered already, sir.
Oh, okay. Thank you very much, sir. All right. So any questions, please indicate, unmute and just ask your question. Dr. Nkanta says interesting and educative presentation. And Dr. Danjuma Tunga says kudos. How expensive is a full treatment? Over to you, Dr. Gilbert, sir.
Sorry, I didn't get that.
Dr. Danjuma is asking how much is a full cost of treatment?
Okay, for us here in FMC, we are working together with an NGO. It is called HANS, it's an acronym. They are based in Jos and they work with orthopedic hospitals all over the country. The material, even with right from the POP, soft band, material for tenotomy, and the braces, these miracle fit braces are provided free. What we do is that there are two categories of patients that we have. Once you come and we assess you and we know that we will do the full treatment without going to theater, that means you have come early. It means that we'll finish the full treatment in our clinic without having cause to go to theater. The mild tenotomy we do it in the clinic, and the materials have already been provided. So the only thing that a patient gets or uses his money to get when he enters FMC is to register with the hospital and have the card and get referred to the Klopu clinic. From there, all the treatment is free, except a patient that comes late and we assess and know that we'll end up in theater, like these ones that I've shown that we have operated, some of these ones that we have operated in the past few weeks. Once we know that we are not going to end up in the clinic, we tell you straight off, because that NGO doesn't cover anything out of the clinic. Once you're going to theater, you bear the cost. So normally, for a patient that may be going for Achilles tendon lengthening and posterior medial releases and all those osteotomies, they cost, since they're children, they cost, theater cost is like 60,000, and then the materials, just the materials, we use the materials that are already in the clinic for them. So it's not that expensive. Once we have operated, we still continue to use the POP and then the other materials for the casting.
Thank you very much, sir. Dr. Danjuma responds that that's good news. Then Dr. Beatrice says, nice presentation. While Dr. Nkanta asks, are there obstetric problems associated with tallipes?
Yes, there are. I mentioned, I was trying to rush, but if you go back to the theories, there is the packaging theory. We talked about the theories just in passing, but there is this packaging theory, which results in the postural crop-put congenital tallipes equinovarus that we talked about. This packaging theory is just tries to tell you that in utero, there are some things that are competing in that uterus, making the feet to be placed in some awkward position. And when the child comes out, it comes out with a foot that looks flopped. For example, if we started by talking about primogravidas. Primogravidas are very tight
uteri. So you can, it's always a given when somebody says, this is my first child and it's coming to clinic. So you can imagine that maybe that womb was tight and then the child was lying awkwardly. People that have twins or more than have triplets and above, these children too compete for that space, and they feed. Nobody can say how they will lie there. So some come out with postural CTEV. If there are fibroids, they will also be competing with that space, and so on and so. Oligohydramnios, which I mentioned too. Anything that will make that environment to be congested will result in the postural type. Remember, we said there are the postural or the extrinsic type, and then the fixed or the intrinsic type. We are very happy when we see the postural type, because you know that when you do 2 or 3 manipulations, the foot will be corrected, compared to the one that maybe has a problem with the tendons, with the ligaments, or has problem with the capsule. So these ones are contracted and so on and so forth. You may need to take some time before you're able to actually stretch them and bring them to normal. So it's a fine question. There are many obstetric conditions that can result in congenital tallipes equinovarus.
Thank you very much for that insightful response. In the absence of any other questions or indications for questions, we'll now look towards the end of this presentation. We want to thank the presenters for taking out of their time and experience to teach us. Indeed, the knowledge passed has been very useful. And for any other questions we may have, we can always direct them to the presenters who are a part of us. We would also like to mention that our CME event tomorrow morning starts by 9 a.m. The links will be shared before that time. The slides also for this presentation, as well as the recording, will be made available also before that time. I will, in this light, and having come to our presentation, I would like to say thank you to everybody for joining in and wishing us all a good evening. We'll see you tomorrow. Thank you.